Hello everyone, welcome back to my channel. So today we are discussing part 2 of the first case in ITO series. You can go back to the other video, which is part 1 of this series, where I've given you the introduction of the case we're discussing today. This is titled as extubation issues because this patient had difficulty extubating. To follow up on that, we are going to discuss how do we assess a patient is ready for extubation. So before we extubate someone, we have to see whether the indication of intubation has been reversed. So in our case, the airway compromise, which led to intubating the patient. Since the patient became awake and alert and following commands, we have successfully reversed the indication for intubation. And that was secondary to overdose of amitriptyline, which over time has washed out of the system and she's overcome that acute phase of side effects of the drug itself. So the second thing is to see if they're hemodynamically stable. So hemodynamic stability is when this patient is off vasopressor support. So any drugs such as noradrenaline or adrenaline infusion or vasopressin infusion given to increase the blood pressure or mean arterial pressure. So she was off all sorts of CVS support, which is cardiovascular support. The third one is respiratory support or ventilator support. We want someone who has least or minimal ventilatory support to be ready for extubation. What do I mean by that is the FiO2 requirement. FiO2 stands for fraction of inhaled oxygen, is less than 40%. So if you think about it, the room air is 21%, and then we calculate FiO2 requirement based on the percentage. So it can range anywhere from 21%, which is basic room air, to 100%. So if the patient is somewhere around 40% requirement or less than 40%, that's when you say they are on minimal oxygen requirement or ready for extubation. The other factor is the PEEP, which is positive end expiratory pressure. So it is the pressure exerted onto the alveoli in expiratory phase so that they don't collapse. So 5 is like the minimal or basic amount of PEEP you can give. The other is the respiratory rate if they're having a respiratory rate less than 30 and their saturations are more than 90%. You would also want to do a blood gas just before extubation to see their pH levels and other PCO2 and PO2 in the blood gas as well. And you want them to be around the normal range. You want to see if trail them on SPONT. So there are different modes on the ventilator setting, and SPONT trial is spontaneous, which means that the patient is taking their breath by themselves and the ventilator is supporting the breath, but the patient is the one who's initiating them. So spontaneous trial means both the patient is awake to take their breaths. Second thing, that they are generating enough inspiratory effort to maintain the tidal volume that they need. So ideally you want them to be on spontaneous mode of ventilator for about at least 1 to 2 hours to make sure they're not tiring on a spontaneous mode. And the other thing is to do a leak test. So leak test is where the cuff that is for the ET tube. So you would deflate the cuff and listen for any leak. Ideally you would want the air to leak when the cuff is deflated. So if you imagine the cuff, there's a tube in place, the ET tube, and there's a cuff which is inflating, and this is causing airtight seal, or ideally you would want a tight seal so that the air is not, there's no leak from around the ET tube. But when you deflate the cuff, you would want the air to leak around the ET tube. This would cause some sort of noise. So you would listen to that noise and see if there is enough leak. If you don't hear any leak, that means the airway is quite edematous. This could mean that if you extubate the patient, the airway is quite edematous and this would lead to stridor and probably a failed extubation. The other thing is the airway protection. So you would want to see whether the patient is able to cough and gag and whether that is a decent cough and gag. So the patient, once they're off sedation and they're awake, they would start gagging because it's a foreign body in their throat, and that will tell you the gag reflex. The cough reflex you can initiate it by trying to do an inline suction, wherein the suction catheter goes into the ET tube, and when it stimulates the mucosa of trachea, then the patient starts to cough. So you would want to see that. And the other thing is neurologically they have to be alert. So you can check that by asking them to follow commands. What I've noticed is sometimes when the patients have been in the ITU for a long time, they become weak peripherally. It's difficult to elicit following commands when you would want them to squeeze your hand, because they would be so weak peripherally that they might want to squeeze, but they're not eliciting enough power. But that doesn't mean that they're not following commands. So the other way to assess the neurological function of following commands is to ask them to blink eyes or to close their eyes shut and you try to open them. The other way would be to ask them to protrude the tongue on command. So you can ask them to put their tongue out. You can see is you can ask the patient to wiggle their toes instead of arms grasp. They can wiggle their toes better, I believe. You can also ask them to lift their head up, because they should be able to have their core strength. They might be weak peripherally, but you want them to have their core strength, which is to keep the head up straight. So neck holding. So before extubating, you would set up, which is you would make them sit in a semi-upright position, which is like 30 to 45 degrees. And then you would stop the NG feed if they're having any NG feed. Ideally, you should stop NG feed 4 to 6 hours before your extubation trial, because patients who are in intensive care might have issues with gastric emptying or delayed gastric emptying. So 4 to 6 hours is good enough time to help empty all of the contents, gastric contents. Just before extubation, you would want to aspirate the NG tube as well, which would take away any gastric contents, also take away the gastric acid which has been accumulated. You do this because once you're trying to extubate, it elicits a gag reflex again, and there's high chances that they would aspirate or vomit any contents, and this can again lead to aspiration pneumonia. So to prevent that, we do this. The other thing would be to suction your ET tube before extubation. Step 4 would be to have your Yanker suction, which is the oral suction, ready, connected to your suction port. Next is to have your 10 ml syringe ready to deflate the cuff. The other bit will be, once you have extubated, you should have a plan in place of where this patient is going to transit. In the sense, once you take the ET tube out, is this patient going to be left to room air, which is very rare, or do we want to put them on a humidified face mask, or do you want them to be on CPAP or NIV? So this would be based on their background. If they have any background of using NIV support or CPAP support, or if they have any tendency to have pulmonary edema or tendency to have CO2 narcosis, then you would want them to be on CPAP or NIV respectively. So this is the interface you have to plan about it. Also, you should always have an emergency intubation trolley ready by your bedside, because for any reason, if this becomes a failed extubation, you would want things ready in hand. Also have some medications like nebs and furosemide, steroids ready in place, just in case if you need them. Once you've done this, then it comes to the actual extubation, where after you've propped them up, you've suctioned the ET tube, you have aspirated the NG tube, then you would deflate the cuff, untie your ET tube, whichever way you have secured it, you would untie it. I was told that it is better to extubate the patient while you are suctioning it. That means you would suction the ET tube. After deflating the cuff, you would suction it via inline catheter, and then you would slowly extubate the patient as well. So this way, any contents which is both tracheal secretions or oral secretions which you might come across while extubating is also suctioned. So this leads to least chances of VAP, which is ventilator-associated pneumonia, and aspiration pneumonia. Another important thing to remember is always have your bag mask valve ready or Michelson C circuit ready while you're extubating. This could mean that any time which the patient is desaturating between your extubation and your putting on to the next interface or your re-intubation, you are ready with rescue respiratory support. Then the issues with extubation could be that the patient has upper airway obstruction, which could mean laryngeal edema, which we discussed about, or trauma to the airway, which would lead to, again, airway obstruction. In these cases, you could give them adrenaline nebs, you can give them steroids to see if that helps. For airway clearance, which means that there's a lot of secretions and they're not able to protect their secretions and they're aspirating on their own secretions. So you could do a chest physio and then do cough assist to help with the secretions. The other is respiratory failure. That means for any case you've extubated them, put them on the interface you've decided, and patient starts to desaturate and you do a blood gas and they are in respiratory failure, which could mean type 1 respiratory failure, where your partial pressure of oxygen is low, or your PCO2 is high, which is type 2 respiratory failure. You might want them to be on NIV or CPAP as per need. Other issue could be aspiration, that they've already aspirated and they're desaturating, so you have to intubate them. So if these issues cannot be managed, then you would have to re-intubate them. The next topic we should discuss is tracheomalacia, because the patient we were discussing has tracheomalacia or suspected to be having tracheomalacia. So tracheomalacia is weakening or softening of the tracheal cartilage, and this can be congenital or acquired. So congenital happens at birth, as it means, and it would improve in 2 to 3 years of age, whereas acquired could be due to any tracheal procedures, any surgeries, or any external compression on the trachea. Then it could mean a tumor or goiter which is compressing on the trachea itself. It could also be due to secondary to autoimmune disorder like relapsing polychondritis. That during expiration phase, this trachea starts to collapse. Diagnosis wise, you can see this on a dynamic CT scan. So during the CT scan, they would ask the patient to take in a deep breath and exhale. And during expiration phase, you see that the trachea starts to collapse, and that is more than 50% of the circumference of the trachea. Another method to see is during bronchoscopy, where you're visualizing the collapse of the trachea. Symptoms of this would be that there's a wheeze and stridor, and in spite of giving nebulizers, this stridor does not settle. Treatment for this would be NIV. You're trying to keep the trachea open by positive pressure ventilation. The other ways would be tracheal stenting, which is again a procedure, or tracheobronchioplasty, which is reconstruction of the posterior wall of trachea and bronchi. The other topic we wanted to talk is the brachial neuritis and how that can cause diaphragmatic palsy. So this has a Parsonage-Turner syndrome. It is an idiopathic inflammatory neuritis, wherein it has a sudden onset of pain in the arm or at the shoulder, and then leads to inflammation of the brachial plexus. So this can happen secondary to viral infection, secondary to vaccination, or any nerve blocks. Depending on which of the nerves of brachial plexus is involved, the symptoms can be different. It can range anything from sensory loss of motor power, or weakness, and it can also lead to diaphragmatic paralysis if it involves the C3 to C5 nerves, which supplies the diaphragm. It's usually unilateral because of the involvement of that side of the brachial plexus. And your symptoms when it comes to diaphragmatic palsy is that there's difficulty in breathing, especially shortness of breath during night. That is when you lie down. So that is orthopnea. This is because when you're sitting up and your lungs have room to expand circumferentially. But when you're lying down, your lungs have restriction towards the posterior expansion, and you're relying on your diaphragm for most of your expansion. So that's when they become symptomatic and have shortness of breath. And these patients land up in having NIV, especially at night time. And our particular patient was on IVAP setting. So IVAPs is Intelligent Volume Assured Pressure Support. It's a nice name in the sense that it is intelligent, which is kind of like an AI generated tool, and volume assured, meaning that alveolar ventilation is the key component to it, which is targeted. It has both IPAP and EPAP settings. EPAP is peak pressure, which is to keep the alveoli open, and in IPAP you have minimum pressure support and maximum pressure support, which would vary to achieve your ventilation. And another interesting thing is also it has pre-inspiratory time, so time of inspiration, minimum and maximum, and also it has rise time, and a ramp time. So rise time is the time taken to reach pressure for inspiration. It doesn't quickly give the volume, it slowly builds up to attain the volume. So it's more comfortable method, and it fluctuates based on the patient's breathing pattern, so it keeps them more comfortable during night time. If you imagine a patient on NIV, it could be quite strenuous to be on that during the night time because it's kind of like blowing air at your face. But I think this is more comfortable because it's not very harsh breath, it's a slow raise in the pressures, and that's more gentle form. And they have good compliance, I believe. Coming back to the diaphragmatic palsy, so you can see this on the chest x-ray because the particular side of the hemidiaphragm would be raised. So if you have right brachial neuritis leading to diaphragmatic palsy. The right side of diaphragm will be elevated on the chest X-ray, and then you can also do an ultrasound where you can see that the diaphragm is not moving, or it could mean that there's a paradoxical movement of the diaphragm. The sniff test, which is done, it is a fluoroscopic test which shows the paradoxical movement. On deep inspiration, the diaphragm is pushed upwards rather than downwards, and that's a paradoxical movement of diaphragm. Other test you could do is to do a nerve conduction study or electromyogram. Pulmonary function tests could show that the tidal volume is reduced, and the treatment would be here to do some breathing exercise, have them on an IV, especially on IVAP setting, and we could give some steroids if it's acute in origin, because we believe it's due to inflammation. Trial of steroids can be done. So this was the discussion based on the case which we've seen. We'll come up with a different case and then we'll start reading more about. See you, happy learning.